Hello friends, welcome to the show Talk with Your Doc. I am Dr. Prashant Jani, and with us today is Dr. Scott Cassie. He is a bariatric surgeon at Thunder Bay Regional Health Science Center. Bariatric surgery is one of the treatment for obesity. Obesity is increasing not only in America but all over the world, and there are many diseases associated with the obesity like hypertension, diabetes, heart disease and many others. Treatment of obesity involves diet, nutrition, exercise as well as surgery, and bariatric surgery has very important role in the treatment of obesity, and Dr. Scott Cassie is going to guide us on various aspects of bariatric obesity treatment. Thank you, Dr. Cassie, for coming today for the show.
Thanks for having me.
Thank you. Please tell us about obesity and surgery.
Yeah, I think obesity, as you touched on, is a growing epidemic at this point, and really, although we know that there are some non-surgical methods of weight loss, from what we've seen over the years and a lot of research, we think that surgery is the one sustainable method of losing weight that we know remains long-term. And so, as far as we can tell nowadays, for at least a subset of the population who become morbidly obese, we think this is probably the most effective treatment in terms of losing weight and keeping it off down the road.
So, obesity, what percentage of people would need the surgical treatment?
That's very difficult to say. I mean, when we look at surgical candidates, it really comes down to what's known as the National Institutes of Health guidelines, and those are about 20 years old now. Mm-hmm. In terms of the proportion of the population who actually undergo surgery, if you look at the people who meet those criteria, which I think we'll touch on in a few minutes, really only about 1% of eligible or potentially eligible patients actually undergo surgery in North America every year. So it's actually a very small subset of the population. And so we like to try and get the word out because there's a lot of lack of knowledge and misunderstanding about bariatric surgery. Right. So we try to get the word out so that people are aware that this is an option for them, and their family doctors are aware that sometimes a referral to a bariatric surgeon may be an optimal therapy for these patients.
Right. So for one to get bariatric surgery for the treatment of obesity, what are the criteria?
Yeah, so if you look at those NIH guidelines, which are slowly being changed over the years, essentially we look at the BMI or the body mass index. And if a patient has a BMI of 40 or higher, automatically they're considered a potential candidate for surgery. If their BMI is 35 or higher and they have at least one obesity-related comorbidity, so for example, diabetes, hypertension, sleep apnea, the things you touched on earlier, those patients are also potential candidates. Now, when they look at those patients, obviously, they can't have any uncontrolled depression, uncontrolled psychosis. They can't have any binge eating disorders and no addictions to alcohol or drugs. Okay. And of course, they have to be medically stable to undergo an anesthetic that lasts a couple of hours. But outside of those criteria, any of those patients with BMI over 40 or 35 would be potential candidates.
So BMI of 40 means what is the weight range?
Exactly. So you look at their weight range, it depends on height. So everything with BMI is your body mass index really looks at your comparison of your height to your weight. So a typical patient is probably, if you're looking at pounds, at least about 250 pounds or up from there, but it really depends on the patient's height.
Right. So now, once one is selected for bariatric surgery, what are the options of surgery?
So now this has been something that's evolving over many years. There are a few that are now considered outdated, but if you look nowadays, there's essentially probably 4 procedures that are considered current. The first one that's probably the most well-known is gastric banding, where a little Teflon band is placed around the top of the stomach. That band has a little port that sits underneath the skin.
So it will reduce the opening of the stomach probably.
Exactly, and so you can inject that port, and there's a little balloon in the band, and as you inject the port, the balloon fills up and it causes some restriction around the top of the stomach and essentially creates a small pouch at the top of the stomach.
So you can't eat more probably then.
That's exactly right. Now that's something that's been around for probably at least 10 years now. It looked very favorable 10 years ago. I don't think the outcomes have been quite as favorable as we expected. And it's slowly, in my mind at least, being phased out. It is still being done in Canada, but a little bit less so now than it was years ago. The second option is something relatively radical known as a duodenal switch procedure. This is something, again, is a little bit historical but has made a real comeback, especially in the eastern provinces. And essentially it combines some trimming of the stomach into a long narrow tube and then a segment of bypass of the bowel. Now, it's very good for patients with what we call super obesity, so BMIs of like 60 and above. There are some risks with it because it's so radical in terms of how much the bowel is bypassed. Some patients become malnourished. There is a risk of chronic diarrhea and issues such as that, and so we typically reserve it for patients who fit that category of super obesity. Now, the two other procedures that are, and those are both offered here in Thunder Bay, are gastric bypass and sleeve gastrectomy. So with the gastric bypass, we essentially turn the stomach into a small pouch. And that pouch is supposed to be around 30 to 50 cc's in volume. We then pull the small bowel up, attach it to that pouch, and we reattach the bowel distally. So it works well because the patient gets full faster. They can only get in a restricted amount of calories. And what they do eat travels about 1 meter to 1.5 meters with very little to no absorption. And they get distal absorption from there. So it's a nice combination of a restrictive and a malabsorptive procedure. And the sleeve gastrectomy is relatively new. It's come up in the last 8 years as a standard.
I think that is the one commonly done nowadays.
It depends on where you go. Everything with bariatrics is quite geographical. In France, in the US, the sleeve is the #1 procedure.
Is done commonly.
In Canada, at least in Ontario, I would say bypass is by far still the #1 procedure. About 75 to 80% of procedures are gastric bypass, and sleeve is about 15 to 20%.
So what is the mechanism by which all these different surgeries work, and how do they reduce the weight?
Sure. So in terms of the mechanism by which they work, it's primarily due to restriction.
Diet restriction.
Exactly.
Intake.
So intake restriction. So we limit how much food can go in at once. We limit how many calories that patient is taking in, thereby they're going to lose weight. That being said, if you look at some of the procedures like bypass and duodenal switch, there is a malabsorptive component as well. So usually it's a bit of combination of some malabsorption. But when you look at the overall picture as to why these patients lose weight, there's probably some underlying features that we haven't quite figured out yet. Most of us believe that it really comes down to some hormonal changes. There's probably some changes in gut signaling hormones. And so we think that may be some of the underlying cause. And certainly after we do a sleeve gastrectomy, we know that some of the hormones responsible for hunger, namely ghrelin, are significantly reduced after the operation. So
your diet goes down and your appetite goes down probably.
Exactly, that's right. That's right.
So basically it might be reducing your stomach capacity and reducing those hormones and...
Exactly, yeah. There's an increase in, it's a whole science unto itself, but there's an increase in some hormones, a decrease in others, but the basic overall feature is, yes, malabsorption, restriction in calories.
So those patients who undergo surgery, are there any risk associated with it?
Yeah, definitely. So I think if you look, and this has been one of the criticisms historically, I think it was considered some of these operations were very high-risk procedures. And with the introduction of laparoscopy to surgery, where we do everything with a camera and usually 4 or 5 small incisions, typically those risks have been minimized over the last few years. But when we look at post-op complications, we usually divide it up into sort of the immediate post-op phase, that first week or two post-operatively, and then the more chronic phase. And so immediately post-operatively, when we consent patients in the office, we always tell them about the risk of an anesthetic, always a small risk of heart and lung complications. We talk about a risk of bleeding. There's about a 1% risk of a major bleed that would require another operation.
So there are complications associated with this obesity surgery probably?
For sure, yep.
Right? Maybe we can take a short break and we'll talk about the complications in the next part.
Sure, that sounds great.
Thank you. Please come back after the short break.